I think we're ready for the second session, which is regarding the management of aphakia. Previously, patient used to wear aphakic glasses, and if there was any reason of aphakia in one eye, the eye was made aphakic, and to wear high-powered hypermetropic glasses. With time, then they came the lenticules, then the contact lenses, aphakic contact lenses, and then the ACILs. ACILs they themselves have the problems damaging the structures in front and behind and causing glaucoma. And then there are different techniques to get rid of that aphakia with much better way, or with a much better technique. But these techniques are not without any problems. If they are handled by a non-expert person, it can cause retinal detachments and not doing vitrectomy, just putting an IOL. So these are the problems are going to be discussed by the speakers. So the first speakers will be introduced by Dr. Iqbal.
Assalamualaikum. Okay, our first speaker is going to be Dr. Sadiq Iqbal, and he's going to talk on pros and cons of ACIOL and a modified technique for scleral fixation.
Anterior chamber IOL is an older technique which still has some validity and some position in our practice. Indications would be obviously any case of inadequate zonular support and capsular support. Older patients who are more than 50 years of age, patient with adequate anterior chamber depth. This is a shorter procedure, so any patient which cannot undergo a longer surgery, maybe a heart patient, maybe a respiratory illness patient, we can go for anterior chamber IOL in that case. Other rare indication would be contraindication to scleral fixation, like in case of very thin sclera or in high myopia or any case of scleritis. Relative contraindications would be any pre-existing corneal disease or dystrophy, which would contraindicate the use of ACIOL. A poor endothelial cell count, a younger patient that has an age of less than 50 years, there is an angle abnormality or anterior synex, peripheral anterior synex, any iris cases of iris defects, or any case of hypermetropia with small eyeball, less than 3 millimeter of anterior chamber depth. Advantages of this technique is that the materials used are inexpensive, no sutures are involved, it has an easier learning curve, the duration of surgery is shorter, the visual results long term are shown by studies to be equal to scleral fixation methods or other methods. There is no need for extensive anterior vitrectomy. There are lesser complications like IOL tilt, vitreous hemorrhage, suture erosion. Disadvantages are you have to perform a broad-based peripheral iridectomy. The wound is larger, the optic diameter, the shortest optic diameter available in ACIOL is 6 millimeter. So larger wound causes greater surgical induced astigmatism. The most damaging disadvantage is increased chance of angle damage, iris damage, chronic inflammation, elevated intraocular pressure, uveitis, glaucoma, hyphema syndrome. Endothelial cell damage is also very common, and corneal decompensation. Another disadvantage is you will have poor dilation for future diagnostic or therapeutic retinal procedures. But still, this technique is valid, where maybe in resource poor regions in peripheries because of its advantages. My other topic is scleral fixation with a flange technique. The materials used are 50 or 60 Prolene, 24 or 25 gauge needle, which is used to feed this suture. PMMA lens with 6.5 millimeter optic is used, which has special eyelets in the haptics. You also need an AC maintainer or pass planar infusion port to maintain the stability of anterior chamber. Um, if you look at the structure which is formed, the lens being secured by flanges of the suture which are made by thermal cautery, we see that if you perform a stress test, one would figure that the weakest point is at the base of the flange, but rather that is very secure and the optic haptic junction breaks rather than the base of the flange. Looking at the technique, a thorough anterior vitrectomy has to be done. Pars plana infusion port is already been made. We feed the 50 proline suture through the eyelet of haptic in this lens, and we test the flange size. Either it will remove on its own or no. We secure both haptics by this suture and create a flange. This lens has a optic diameter of 6.5 millimeters and will, now that both the haptics are secured by 50 proline and its flanges, we make a main incision, enlarge it up to so the site of scleral fixation is 1.5 to 2 millimeters away from limbus, and this 23 gauge needle is used. You can also use 25 or 26 gauge needle, which is better for the scleral tunnel. You feed the other end of the haptic, other end of the suture in it, and secure it like such. This process is repeated on the other side as well. Suture is very easy to handle as compared to 10-0 proline used with similar lens in other technique. Same process is repeated on the other side. In this step, care is taken to not cut the suture when you are expanding the wound. Herein does lie a disadvantage of this technique because of large scleral wound. Pars plana infusion is used as needed. Main wound has to be secured with a 10-0 nylon. You leave around a 1.5 to 2 millimeter end of the flange and secure it in the scleral tunnel. One can see the suture has been buried into the scleral tunnel. Advantages of this technique is that cheaper IOL has been used, and this technique has an easier learning curve because the suture handling is very easy. The flange creation method is easy. It is a durable suture as compared to 10-0 proline, which has a life of around 9 to 10 years. And it is difficult to handle and breaks upon handling. The other advantages are better stability in terms of IOL tilt. This was seen in a study of 80 cases of comparison with 10-0 Pauline Malbrin IOL fixation technique. Other advantages were lesser risk of IOL capture as opposed to conventional scleral fixation. Disadvantages are involving the suture. You can see scleral suture erosion through conjunctiva or tenon, which increases the endophthalmitis risk. Non-foldable IOL has been used, so there is a larger incision causing surgical induced astigmatism. Thank you.
Thank you, Dr. Saad. Next, I would like to invite Dr. Junaid on technique of posterior fixation IOL, his personal experience. And he is going to demonstrate very good Yamani technique and a few modifications of it.
Assalamu alaikum. I am Dr. Junaid. I am working as consultant ophthalmologist at Al Hanif Clinic, Chang. Today I am going to present posterior fixation IOL using Alcon MA60 AC lens. And in my presentation, I will show you that we can perform the surgery either using 3 ports pars plana vitrectomy or either using only infusion or with anterior chamber maintainer even. I will show you the videos. This is a patient that presents with traumatic cataract and xenopathy.
Scleral fixation by Yamane technique. Scleral fix.
Play करते हैं.
Scleral fixation by Yamane technique. Marking done for 3 and 9 o'clock with the help of a marker. First, an infusion line is secured 3.5 mm posterior to limbus. Residual lens matter is completely removed along with remnant of capsule and thorough anterior vitrectomy is done. Any vitreous entangled to lens surface will cause chronic traction and cystoid macular edema or can even result in retinal detachment. First needle is passed 2 mm away and upwards from the limbus at 3 o'clock position parallel to the final haptic direction. Second needle is passed in the same fashion at 9 o'clock position. Construction of main wound 3.2 mm and injection of intraocular lens with right hand while manipulating the first needle to receive the leading haptic in a handshake fashion. The needle is left in the tract. Trailing haptic is docked to the second needle with the plain forceps through the main wound. You can also use micro forceps if needed. First, the trailing haptic is externalized and a small flange is made with the help of hot point. Followed by externalization of the leading haptic and flange formation. Burial of externalized haptics and flange into the scleral tunnel. Securing the main wound and air bubble injection in the anterior chamber. Infusion line is removed and you can see the stable central intraocular lens at the end of surgery. Scleral fixation.
Second video play नहीं हो रही है. Second video play नहीं हो रही है. First वाली.
Patient presented with mature cataract and recent lung trauma resulting in zonulopathy and subluxated cataractus lens. We decided to go for 3-port PACRS planar vitrectomy phacofragmentation and scleral fixation. 3-port PACRS planar vitrectomy setup done. Calcified capsule and lens remnants are vitrectomized and the whole nucleus is dropped into the vitreous cavity. Phacofragmentation with the help of 23-gauge vitrectomy cutter is done and complete vitrectomy is performed. .360-degree prophylactic laser barrage is applied. Now comes scleral fixation part. 3 o'clock mark is applied 2 mm away from limbus and another mark is applied 2 mm up for the leading haptic. First needle is passed 2 mm away at 3 o'clock position parallel to the final haptic direction. Second needle is passed in the same fashion at 9 o'clock position. Construction of main wound 3.2 millimeters and injection of intraocular lens with right hand while manipulating the first needle to receive the leading haptic in a handshake fashion. The needle is left in the tract. Trailing haptic is docked to the second needle with the plain forceps through the main wound. First, the trailing haptic is externalized and a small flange is made with the help of hot point. Followed by externalization of the leading haptic and flange formation. Burial of externalized haptics and flange into the scleral tunnel. The intraocular lens is well centered as observed in the end of video. Thank you for your attention. Scleral.
So the advantages are the technique is less manipulative, it's completely sutureless, easier to perform, no special instrumentation required, and IOL is more stable and have less astigmatism. Thank you.
Next, it's my turn. So I'm going to present. Okay, my topic of the talk is 4-point scleral fixation. The other variations you have observed before. Now it is going to be a little bit different technique, and I'm going to combine it with the pars plana vitrectomy. The procedure involves limited conjunctival peritomies, and we're going to mark calipers 4 to 5 millimeter apart, 2.5 or 3 millimeter posterior to the limbus, and it is centered around horizontal axis. 4 PACRS you can combine either 25 gauge or 23 gauge as per your availability, and I usually use 23 gauge, which is going to help me in the burial of the suture later on. I am going to do this procedure with a CF4 or a Claire 4 haptic IOL, but internationally it is being used with the Bosch norm Acreos, which is not available in Pakistan right now. 90 Prolene or a Gore-Tex suture can be used to anchor the lens. 90 Prolene, as you all know, has a propensity to lyse and can later on get an IOL subluxation. So Gore-Tex is a little bit better because it is biocompatible and used in the vascular surgery, and it is non-absorbable. So this is the video. So this is the marking site. I am going to mark at 3 and 9 o'clock, and we are going to see the lens which is subluxated posteriorly, and these limited peritomies are being made. And this is done in a hybrid fashion. 225 gauge and 223 gauge cannulas are used. Okay, this is going to be the final fixation position of the lens with its 4 haptics tucked, anchored with the help of the suture. This is a diagrammatic representation.
For haptic intraocular lens fixation. This man presented to us with a subluxated intraocular lens, and we decided to do a 4 haptic lens fixation. First, a trocar inserted in the sclera inferiorly 3.5 mm away from limbus for infusion. Then 3 mm away from limbus 4 trocars are inserted sparing 3 and 9 o'clock positions and approximately 4 mm apart on both sides.
This was previously a scleral fixated lens that was subluxated 8 years afterwards.
Main wound of 5 mm was made to remove the subluxated intraocular lens. Two halves of CV8 Gore-Tex suture are cut and passed through the haptics to make 4 ends.
ओके ये जो सूचर है वो आपका गॉटेक्स सूचर है और इसको हैंडशेक
All
टेक्निक
4
से
ends are externalized through the trocars, making the 4 anchor points ready for the lens.
सो आपने ऑल 4 एंड्स निकाली है बाहर और जो सूचर है वो रेडी है टू होल्ड दी आईओएल. इस स्टेप के ऊपर सबसे इंपॉर्टेंट चीज यही है कि आपने जो पैटर्न है उसको बहुत अच्छे से फॉलो करना, वरना ये एंटेंगल हो जाएगा. और
Then the lens is inserted into the anterior chamber and suspended behind the iris.
ये चूंकि मैंने पीएमए में लेंस निकाला था तो इसमें वूंड बड़ा है. अदरवाइज अगर वूंड स्मॉल हो तो आप आईओएल फॉर्सेप्स के साथ इसको फोल्ड करके भी डाल सकते हैं. बिफोर जैसे जितनी पिछली टेक्निक्स में भी सारी यही डिस्क्रिप्शन हुई है कि अगर आपका वूंड स्टेबल नहीं होगा तो आपकी जो स्क्लेरल फिक्सेशन है वो स्टेबल नहीं होगी. इसमें बिफोर टाइम द नॉट यू हैव टू apply a suture and keep the anterior chamber stable.
The sutures were tied with a 3-1-1 knot and tension on the suture was adjusted to centralize the intraocular lens. The knots along with suture loop are rotated to bury the knots intraocularly.
हमारे जो रेगुलर सूचर्स हैं उनके अंदर हम नॉट्स को हैंडल नहीं करते, लेकिन गॉटेक्स इज एन एक्सेप्शन. इसमें आपको इतना स्लिपरी होता है कि आप सूचर को नहीं पकड़ सकेंगे अगर आप नॉट को हैंडल नहीं करते तो. सो यू हैव टू लिटरली होल्ड द नॉट एंड bury it inside.
Post-operatively, the lens is central and patient has 6/9 vision unaided.
So ये 6/9 vision है unaided इस patient की. And now coming to the advantages over 2-point fixation, very beautifully done, explained by Dr. Junaid. But in here, the advantage is that it reduces the chance of IOL tilt and astigmatism. So final induced astigmatism is very less. And there are no chances of haptic optic junction damage. ईमानी टेक्निक के अंदर जब आप हैप्टिक्स को मैनिपुलेट कर रहे होते हैं तो देयर इज ए चांस कि आप जो है वो हैप्टिक को उससे तोड़ दें. यहाँ पे कोई हैप्टिक टूटेगा नहीं क्योंकि वो सारा का सारा सूचर के साथ होल्ड हुआ है. इजियर टू परफॉर्म है मैं ये कह सकता हूँ, लेकिन मे बी लोगों को लगे कि ये डिफिकल्ट है, बट फॉर एज ए रेटिनल सर्जन इट इज वेरी इजी टेक्निक एंड इट कैन बी कंबाइंड विद द पोस्टीरियर सेगमेंट सर्जरी, जो कि मैं भी आगे दिखाता हूँ आपको कि ये न्यूक्लियस ड्रॉप के साथ किया गया जहां पे हमारे पास लिमिटेड कैप्सुलर सपोर्ट अवेलेबल थी. मैंने आपको दिखाया कि वो जो मार्किंग्स हैं और जो मेरे ट्रोकार्स हैं वो पहले से प्लेस हैं, और ये जब इंट्राओकुलर लेंस डाल के उसको हमने टाई कर लिया हुआ एंड इट इज परफेक्टली सेंटर्ड. टू इंपॉर्टेंट थिंग्स के जैसे पहले एक्सप्लेन किया गया कि कोई कैप्सुलर रेमिनेंट या एंटीरियर विट्रस अगर रह गया है तो दैट इज गोइंग टू बी कॉज ऑफ द कॉर्नियल एडिमा, सॉरी मैकुलर एडिमा. और अगर कोई आपकी ब्रेक है रेटिना पे और आपने उसको एड्रेस नहीं किया ड्यूरिंग स्टाइल फिक्सेशन, दैट इज गोइंग टू गिव यू अ ट्रबल लेटर ऑन. यू आर गोइंग टू बी फेसिंग सम रेटिनल डिटैचमेंट एंड इट इज गोइंग टू बी डिफिकल्ट सर्जरी फॉर यू. सो व्हेन यू आर गोइंग इनसाइड द आई यू आर गोइंग टू डू एवरीथिंग वंस एंड परफेक्टली. ये जो कैप्सुलर रेमिनेंट था ये बीच में आएगा लेटर ऑन, तो उसको हमने पहले डिसलॉज किया फिर कटर से रिमूव कर दिया. क्योंकि अगर ये रहेगा तो ये लेंस को टिल्ट कर देगा, आपकी फाइनल पोजीशन नहीं आएगी. और आपने हमेशा इंडेंट करके चेक करना है. जैसे कि इस केस के अंदर हमें एक ब्रेक मिल जाता तो आइदर यहाँ पर 360 डिग्री प्रोफिलेक्टिक ब्रांच कर दें या आप जो प्रोबेबल ब्रेक्स हैं उनको लेस कर दें. एंड चूंकि ये सूचर वेस्कुलर सर्जरीज में यूज हो रहा है, हार्ट सर्जरी में यूज हो रहा है, इट इज गोइंग टू बी देयर फॉर ऑल हिज लाइफ टाइम और सूचर लाइसिस का सवाल ही पैदा नहीं होता. So that's all. Thank you. And with this, I would like to invite Dr. Tariq Khan for his 2 videos जो कि और इससे related हैं, skull fixation से related.
Now, beautiful techniques to obtain the vision. Now, this was a patient which was operated elsewhere with a multifocal IOL and it was tilted downwards. So I planned, yes, the haptic nazar, I'll just do a single haptic fixation. So if you see, after doing the anterior vitrectomy and then I'm trying to manipulate that lens to take it out one haptic, but when I tilt, leading haptic hai hi nahi, is broken from the junction of the haptic and optic. अब सर्जन का कमाल है कि उसने वह लेंस वैसे डाल दिया, इनसे मल्टीफोकल IOL पैन ऑप्टिक्स. तो अब इसका क्या किया जाए? Could we do something other than to take this lens out and place it with another, replace it with another lens, but not multifocal? So ये देखिए, एक उसका जंक्शन ठीक है, दूसरे जंक्शन पे है ही नहीं वो लेंस. So please do not do that. पेशेंट को पहले आप उसको समझाएं. There can be problems. You can always tell the patient after the surgery that this was the problem and this was the reason I didn't put an IOL, which you can do it afterwards. But that created a misunderstanding between the main surgeon and the patient. So he went somewhere else. तो इसका मैंने फिर ये लेंस निकाल के I put in 6.5, उसका monofocal lens after explaining everything. Or the patient was very satisfied after the counseling. So can we have the next video? So never do that. आपने इतने पैसे से लिए हुए हैं, nothing will happen. ये देखिए मल्टीफोकल लेंस उसने डाला हुआ है, उसको एक्सप्लेन करें पेशेंट को. सो दिस वाज अनदर, इसका 15 साल हो गए थे इसके लेंस को डले हुए, मल्टी पीस. अगेन इट वाज सनसेट सिंड्रोम, द लेंस वाज डाउन. सो आई ट्राइड कि इसका सिंगल हैप्टिक फिक्सेशन देखते हम करते हैं या इस IOL को रिमूव करके 2 हैप्टिक फिक्सेशन करेंगे. सब चीजें पेशेंट को एक्सप्लेन की हुई थी. सो ट्राई टू रोटेट इट. इसका एक हैप्टिक मैंने बाय लिया in the anterior chamber and then with Vizilon and cannula, I just lifted the lower haptic and redialed. वो खुदा करना वो redial होके उसका जो inferior haptic था, it again went back to the sulcus, and there was enough sulcus. Then I rotated the other haptic into that sulcus, and it was again. Then I tried to manipulate ऊपर नीचे कि ये नीचे तो नहीं जाता. So it was redialing the low haptic into the sulcus. There was no PC. Center में नहीं था. Right? So ऊपर से redialing के लिए मैंने made a new port. Instead of redialing it, उसको हम पकड़ के इसको उसके पीछे iris के पीछे ले गए उसी plane में. Vizilon यहाँ पर डालना है चाहिए आपको हर वक्त. Otherwise you can damage the endothelium. So instead of dialing it, I'm just pulling it and taking into that space. There you, the lens is in the center, it's in sulcus. I manipulated it with the dialer and with the cannula, so it's well stable. और उसको तकरीबन 6 हफ्ते हो गए, the patient is happy. So these were two things. Always explain the things beforehand to the patient and never try कि मैंने इतने पैसे लिए वो लेंस मैंने डालना ही है. There was a patient from RB, डॉक्टर काजी के पास गया, डॉक्टर काजी बात सुनाते हैं. वो कहते हैं मुझे बता दे मेरी आंख में IQ डला हुआ है कि नहीं डला हुआ. And the IQ was on the macula. उन्होंने कहा IQ डला हुआ है. कहते फिर ठीक है. डला पहले it was lying on the knee. कई सब बताते हैं अपनी प्रैक्टिस में. So never do that. Always tell the right thing to the patient. वक्ती तौर पे होगा लेकिन second surgery में उसको compensate करें. The patient will be happy. Thank you very much.